And then this statement by the American Congress of Obstetricians and Gynecologists. Texas ACOG statement opposing Texas fetal pain legislation. And this comes from District 11 of that particular organization. The Texas District of the American Congress of Obstetricians and Gynecologists, Texas ACOG, opposes HB 16 by Representative Laubenberg. Texas ACOG opposes HB 16 and other legislative proposals that are not based on sound science or that attempt to prescribe how physicians should care for their individual patients. As a district of the nation's leading authority in women's health, our role is to ensure that policy proposals accurately reflect the best available medical knowledge. Terminology. The use of appropriate standard terminology is essential. A child is a person from birth until the age of legal majority. The proper term for the 2nd to 8th week is embryo. The embryo becomes a fetus at 10 weeks. The term fetus is the correct term to use until birth. The language regarding post-fertilization age is rarely used outside in vitro fertilization. The post-fertilization age of the embryo or fetus is not known. There is inherent variability in the timing of ovulation, fertilization, and implantation. Obstetrician gynecologists and the medical community at large use the first day of the last menstrual period, LMP, to date pregnancies. Post-fertilization dating is not an accurate substitute and should not be referenced in legislation. Fetal pain. The statement, quote, substantial medical evidence recognizes that an unborn child is capable of experiencing pain by not later than 20 weeks after fertilization, end quote, is not accurate. And of course, members, we know that that quote was in the bill analysis as well as in the bill itself. The medical profession produced a rigorous scientific review of the available evidence on fetal pain in the Journal of the American Medical Association, JAMA, in 2005. Pain perception requires conscious recognition or awareness of a noxious stimulus. Neither withdrawal reflexes nor hormonal stress responses to invasive procedures prove the existence of fetal pain because they can be elicited by non-painful stimuli and occur without conscious cortical processing. Fetal awareness of noxious stimuli requires functional thalamocortical connections. Thalamocortical fibers begin appearing between 23 to 30 weeks gestational age, which electroencephalography suggests the capacity for functional pain perception in preterm neonates probably does not exist before 29 or 30 weeks. The review concluded that fetal perception of pain is unlikely before the 3rd trimester. More recent studies confirm that finding. The Royal College of Obstetricians and Gynecologists, ARCOG, is the UK-based equivalent to ACOG, with 12,500 members worldwide and representation in over 100 countries on all 6 continents. In 2010, ARCOG rigorously reviewed the scientific literature and, quote, in reviewing the neuroanatomical and physiological evidence in the fetus, it was apparent that connections from the periphery to the cortex are not intact before 24 weeks of gestation, and as most neuroscientists believe that the cortex is necessary for pain perception, it can be concluded that the fetus cannot experience pain in any sense prior to this gestation, end quote. Supporters of fetal pain legislation only present studies which support the claim of fetal pain prior to the 3rd trimester. When weighed together with other available information, including the JAMA and ARCOG studies, Supporters' conclusions do not stand. Fetal viability. Most obstetrician gynecologists understand fetal viability as occurring near 24 weeks gestation, utilizing LMP dating. Supporters of fetal pain present misleading evidence about fetal viability, especially in using post-fertilization age instead of LMP dating, falsely implying high survival rates among neonates that are overwhelmingly pre-viable. Supporters may point to the survival of live-born infants in a June 2009 JAMA study, but fail to mention that the vast majority of infants born prior to 24 completed weeks LMP died prior to or during birth. In this study, 93% of infants at 22 weeks died, 66% at 23 weeks, and 40% at 24 weeks. 91% of those that lived were admitted to the NICU. Also not mentioned by supporters is the fact that survival alone is not the only endpoint for neonatologists. Intact survival is. In this same study, 98% of infants born at 22 weeks LMP and 91% born at 23 weeks LMP had at least one major medical problem, such as hemorrhaging brain or bowel. The American Academy of Pediatrics Committee on Fetus and Newborn states that the incidence of moderate or severe neurodevelopmental disability in surviving children assessed at the age of 18 to 30 months is high, approximately 30 to 50%, and remains at that high level until 25 weeks LMP. Babies delivered at these gestational ages often suffer hemorrhaging bowel, blindness, deafness, and stroke as a result of their premature delivery. Fetal anomalies. Many fetal anomalies can be diagnosed before 20 weeks. Others are not diagnosed until around 20 weeks. HB16 provides an inadequate exception for severe fetal abnormalities. This exception puts into statute how a doctor should exercise medical judgment and interferes with the private nature of deciding what to do when a fetus has been diagnosed with severe fetal abnormality. There are numerous fetal anomalies that are regularly detected only after 20 weeks. While chromosomal anomalies can generally be diagnosed by 20 weeks, some low-risk couples do not elect to have testing and instead learn that their fetus has a chromosomal anomaly during routine ultrasound later in pregnancy, an ultrasound that is often performed at 18 to 20 weeks gestational age. Moreover, many lethal or serious fetal problems that are not compatible with life outside of the womb are caused by conditions that are structural, not chromosomal, and are not susceptible to testing by amniocentesis. These can only be diagnosed by detailed ultrasound examination. Many tests cannot definitively diagnose grave conditions affecting a pregnancy prior to 20 weeks because the fetus is not sufficiently developed for those conditions to be detected, even in cases where an ultrasound detects indications of a structural anomaly prior to 20 weeks. Additional tests, such as amniocentesis or echocardiogram, are often necessary to confirm the diagnosis. Scheduling those additional tests and obtaining the results will take additional time, often up to 2 weeks. By the time a diagnosis is confirmed by a specialist capable of diagnosing these anomalies, the pregnancy has often progressed beyond 20 weeks. As a result, a woman whose fetus is critically impaired often will not learn of that fact until well into the second trimester. The medical difficulty, if not impossibility, of diagnosing many of these lethal structural defects before 20 weeks is heightened by the fact that additional tests and doctor's appointments are often needed to confirm the anomaly as discussed above. Once the diagnosis is confirmed, many couples need additional time to make a well-informed, careful decision about whether to terminate a wanted pregnancy. General obstetricians who suspect a problem based on an ultrasound at 18 to 20 weeks often refer their patient to a perinatologist, the relevant specialist, for confirmatory study and then diagnosis. These confirmatory tests take additional time, sometimes several weeks, to schedule and obtain results, particularly for women who live in rural or underserved areas. The final diagnosis will thus regularly take place near or after 20 weeks. Life of the mother. HB16 provides a limited exception for the life and health of the mother. However, it fails to entirely protect women for whom pregnancy poses serious health risks. Under the exception in HB16, a physician can perform a termination only once a medical condition has so compromised the woman's health that she requires a, quote, immediate abortion, end quote, in order to, quote, avert her death or a serious risk of substantial and irreversible physical impairment of a major bodily function, end quote. By requiring doctors to wait until a woman faces immediate injury or death, it indefensibly jeopardizes a patient's health. ACOG opposes HB16 and strongly urges the legislature to closely examine and follow scientific facts and medical evidence in its consideration of this and other healthcare legislation. We stand ready to provide you with factual information on medical issues that come before the legislature and hope you will contact us at any time. And it's signed respectfully, Lisa M. Hollier, MD, MPH, FACOG, Chair of the Texas District of the American Congress of Obstetricians and Gynecologists.